Hello everyone, welcome back to the series of lectures in endocrinology. Today we will be discussing about complications of diabetes mellitus. So let's begin. So the first complication that we should be aware of is your acute disorders related to severe hyperglycemia. So basically these are the group of disorders which are associated with a blood glucose levels of more than 250 mg per deciliter. So the three disorders that we should be aware of are your diabetic ketoacidosis or your DKA, then your hyperglycemic, hyperosmolar state, or your HHS, and the new group of disorders under this is your euglycemic DKA. There is a euglycemic DKA as well. The odd feature about euglycemic DKA is that the glucose levels are normal or less than 250. So the disadvantage is that this will be picked up a little later. And it is associated with what use? It is associated with the use of SGLT2 inhibitors. So a very important side effect of SGLT2 inhibitors is your euglycemic DKA. Okay, so let us understand the hallmark features and the pathogenesis of your diabetic ketoacidosis. The hallmark feature is that there is uncontrolled hyperglycemia. And there is absolute insulin deficiency. Okay, so whenever there is uncontrolled hyperglycemia and absolute insulin deficiency, there is increased lipolysis, increased free fatty acid formation, increased ketogenesis, and hence ketoacidosis happens, or there is increased ketone body in the blood. Okay, so absolute insulin deficiency results in increased free fatty acids. These free fatty acids are moved towards your ketogenesis pathway, and hence there is increased ketone body formation in the blood. Apart from this, there is an unbalanced increase in the counter-regulatory hormones, which is your glucagon. There is unbalanced increase in the counter-regulatory hormones, which is your glucagon, and hence there is increased gluconeogenesis, increased glycogenolysis, and the net effect is that there is increased glucose in the blood. This increased glucose in the blood acts as an osmotic substance, and there is glucose uria and dehydration. There can be excessive glucose uria and dehydration. Okay, so if this dehydration is too much, then the serum osmolarity can increase and there will be hyperosmolarity. Okay, so this hyperosmolarity results in your HHS. So the main difference between your DKA and HHS is that in DKA there is more tendency towards ketone body formation. Though they can also have dehydration, there is more tendency towards ketone body formation. In HHS, what happens is that the glucagon excess is a little less when compared to DKA. So your counter-regulatory hormones are elevated, but the elevation here is much more. So since they are not elevated to that extent, what happens is that they do not have much of ketone body formation. So this pathway where the absolute insulin deficiency is more free fatty acid, more ketone body formation is not there in HHS. So the ketone body levels are normal in HHS, but they have hyperosmolarity, which is not seen in DKA. So HHS has more of hyperosmolarity because they have more glucose uria, more dehydration. Okay, so this is your principal pathophysiology difference between DKA and HHS. In your euglycemic DKA, this is associated with SGLT2 inhibitors. The main mechanism of action of your SGLT2 inhibitors is that they promote glucose uria. So in these patients, because of your promotion of glucose uria, the glucose levels are normal, but you can have DKA. So this is your euglycemic DKA, which is very important, or something that you have to watch out for in your SGLT2 inhibitor use. Okay, clear? So this is about your pathogenesis of DKA. Now let us move forward and understand what are the clinical features. The major symptoms with which DKA presents is nausea, vomiting, abdominal pain. So it can present with nausea, vomiting, abdominal pain. So we were discussing about the different medical causes We have discussed about the different medical causes of abdominal pain. This includes your adrenal insufficiency. This includes your adrenal insufficiency. It includes your diabetic ketoacidosis. It also includes hypercalcemia. It also includes hypercalcemia. So, DKA is one of the medical causes of abdominal pain. DKA is characterized by nausea, vomiting, abdominal pain. Now, when the ketone bodies accumulate in the blood, they are acidotic in nature and it causes acidosis. Whenever there is acidosis in the blood, the type of breathing pattern that you will have is called as Kussmaul's respiration. You will have Kussmaul's respiration. So, whenever there is metabolic acidosis, what is your respiratory compensation? We have listened to our lectures on nephrology. You will understand that whenever there is metabolic acidosis, the respiratory compensation is by CO2 washout. We try to wash out the CO2 from the body because CO2 is also acidic. So, you want to remove CO2 from the body by hyperventilation. So, this hyperventilation results in what we call as your Kussmaul's respiration or your increased rate of breathing as a compensation for the metabolic acidosis. So, this presents with the symptom of breathlessness. Okay, so you can have nausea, vomiting, abdominal pain and breathlessness. So, what are the precipitating factors? So, DKA is basically a acute condition and it is a severe condition with a high mortality rate if it is not treated promptly. So, what are the precipitating factors for DKA? It can be infections like a UTI, like a pneumonia. Then, patients of type 1 diabetes on insulin, if you suddenly stop your insulin, there can be absolute insulin deficiency resulting in DKA. Infarctions like an MI or pulmonary thromboembolism. Then, pregnancy, pancreatitis, all of it can precipitate DKA. So, what are the clinical findings which are seen? There can be tachycardia. Because of osmotic diuresis, when the glucose is getting excreted in the urine and osmotic diuresis, you can have dehydration. Tachypnea because of your acidotic breathing. You can have abdominal tenderness and lethargy. Okay. In HHS, what happens in HHS is that because of your hyperosmolarity, you can have cerebral edema and the patient can be in coma. There can be confusion and coma as well. Okay. So, this is about the various clinical features of DKA. Now, let us understand the major differences between your DKA, HHS and your euglycemic DKA. So, glucose levels are around 250 to 600 in DKA. They are much higher, about 600 to 1200 in your HHS. Euglycemic DKA, as the name suggests, is euglycemic. So, your sugar levels are normal in your euglycemic DKA associated with SGLT2 inhibitors. So, you have to have a high degree of suspicion for DKA and get your urine ketones and serum ketones, get an ABG done if you are suspecting euglycemic DKA. So, it is little difficult to pick up. Then, sodium levels. What happens to the sodium levels? The sodium levels are slightly low in your DKA. The sodium levels are slightly low in your DKA, but the sodium levels are normal in your HHS and in your euglycemic DKA. Okay. Then, potassium levels will be normal, magnesium levels normal, chloride levels are normal. Phosphate levels are normal as well. What happens to the creatinine? The creatinine will be moderately increased in your HHS because the degree of dehydration is more and there is hyperosmolarity. You can have pre-renal AKI. So, the degree of dehydration is more in HHS and the creatinine can be slightly increased. What about the osmolarity? As the name suggests, the osmolarity is much higher in your HHS ranging from 330 to 380. Normal is 280 to 290. Serum or urine ketones and serum beta hydroxybutyrate, which is your ketone bodies, are positive in your DKA and euglycemic DKA, but they are negative in your HHS. So, basically your ketone body formation pathway is not much active because your counter-regulatory hormones are not that elevated in your HHS. Okay, fine. Then serum bicarbonate will be low. So, basically acidosis is there in your euglycemic DKA and DKA, but there is no acidosis. Serum bicarbonate will be more than 18 in HHS. Arterial pH will be low. Arterial pH will be normal in HHS. arterial PCO2 will be low, arterial PCO2 will be normal in HHS. High anion gap metabolic acidosis, so a widened anion gap is seen in DKA, and in euglycemic DKA it is not seen in HHS. So these are the basic biochemical differences between your DKA and HHS. Fine. So let us look at the treatment algorithm for your DKA. So what is the treatment algorithm for your DKA? So the first step will be you have to confirm the diagnosis. How is the diagnosis confirmed? By increased serum glucose levels, increased serum beta hydroxybutyrate levels, and the presence of metabolic acidosis. So increased serum glucose levels, increased beta hydroxybutyrate levels, presence of metabolic acidosis. Then you have to identify that this can be a life-threatening condition, and hence you admit the patient for frequent monitoring in the hospital. Okay. Assess for the serum electrolytes, bicarbonate, phosphate, potassium, sodium, acid-base balance, renal functions including your creatinine. Look at the urine output. So after your assessment of the patient is done and you have identified that this is DKA. So what is your cornerstone management of DKA? So the two most important steps that you have to take in the management of DKA is to correct the dehydration using your IV fluids, and second, bring down the blood glucose levels using insulin which is given IV. Okay. So the two most important steps that you have to take in the management of diabetic ketoacidosis is to administer IV fluids to correct the dehydration, and you give IV insulin. Okay. So the two steps will be give IV insulin, bring down the glucose, and you give IV fluids. So the initial IV fluid that you will give is 2 to 3 liters bolus of 0.9% NaCl. Okay, so the initial IV fluid is 2 to 3 liters of 0.9% NaCl. Or you can give RL as well, Ringer's lactate as well, over the first 2 to 3 hours to correct your dehydration. Okay. At the same time, you have to start insulin. So how do we start insulin? Insulin is not given subcutaneous here. Insulin is given IV. Insulin is given IV, and the dose of insulin will be 0.1 units per kg. The dose of insulin will be 0.1 units per kg. And what insulin do you give? You usually give your regular insulin. You give your regular insulin. So 0.1 units per kg per hour is the dose at which you give your insulin infusion. Okay. So 0.1 units per kg per hour is the dose at which you give your insulin infusion. Okay, fine. And the other way in which is to get an estimate. So for example, if your blood glucose levels are 350, then how much insulin would you like to give? You will give around 3.5 cc per hour. Okay, this is another way of estimating how much glucose or how much IV infusion insulin dose you want to give. Okay, so you start off your treatment by assessing the patient, start off the IV fluids and start giving your insulin. So once you start giving your IV insulin, what do? You will have to check the blood glucose. You will have to check the blood glucose every hourly. You will have to check the blood glucose every hourly. Okay, you will have to check the blood glucose every hourly and you adjust the dose accordingly. For example, if your blood glucose is dropping well and good, then you continue the same insulin infusion dose. But if your blood glucose is increasing, you started at 3.5, the blood glucose was 350 and now it is going 400, then what do? You may have to give a double dose of the insulin. Make it from 3, maybe go up to 6 and then start tapering. So you will have to do a monitoring of your hourly blood glucose. So the initial IV fluid that you give is your 0.9% NaCl, give about 2 to 3 liters. After that, you will have to change it into your maintenance fluid at about 0.45% NaCl, which is your 0.45% NS. Now, once there is improvement in your blood glucose levels, your blood glucose levels have started dropping and it has come to say less than 250 milligrams per deciliter. So once the blood glucose begins to drop to less than 250 milligrams per deciliter, the IV fluid that you are giving is 0.45% NaCl now. But at the same time, you will have to mitigate the risk of hypoglycemia. If you continue to give IV insulin infusion, then there is a high risk of hypoglycemia because the blood sugar levels have dropped. So the other IV fluid that you will add is, in addition to your 0.45% NaCl, you have to give 5% dextrose as well. So that is what is written here. Subsequently, you give 0.45% saline at 250 to 500 ml per hour and change to 5% glucose and 0.45% saline at 150 to 250 ml per hour once the blood glucose drops to less than 250 mg per deciliter. So we have learned in our basics of IV fluid chapter that 5% dextrose is the same as replenishing water. Okay, 5% dextrose basically is the same as replenishing your water itself, because whatever dextrose is there, it gets converted into carbon dioxide and the fluid is basically the fluid gets redistributed in your both intracellular and extracellular compartment. Okay, so you continue with 0.45% NS and 5. So initially you give 0.9% NS, then change your fluid to 0.45% NS and 5% dextrose. Okay, so this is about your fluid and insulin. Now, how do you monitor the patient? How do you monitor the patient? What are the things that you will have to monitor? You will have to monitor your blood glucose every hourly. Apart from that, you will have to check for your electrolytes every hourly or 2 hourly or 4 hourly. Okay, so 2 to 4 hourly you will have to check your electrolytes as well. Okay, so you will have to look for your sodium, you will have to look for your potassium. You will have to do your ABG every hourly, or hourly to 2 hourly you will have to check an ABG. Look for the improvement in your acidosis. Look for the improvement in your acidosis. Apart from that, you will have to monitor for the patient's hydration status. Okay, you will have to see whether you are overhydrating them, right? If you are overhydrating, what will happen? The JVP will begin to rise and you can have bilateral crepitations as well. So look for your hydration status. Monitor the urine out. Monitor the urine out. Okay, so this is about how you initiate the treatment and how do you monitor the patient once you have diagnosed your patient with DKA. So the salient features is about the insulin. We give IV insulin, not subacute insulin. Now, an important point in the correction or management of DKA is about your serum potassium. So we know that insulin, when you give IV, it can cause hypokalemia because it causes intracellular shift of the potassium. So whenever you give IV insulin, it can cause intracellular shift of the potassium. So initially, if there is hypokalemia, initially itself, if the potassium is less than 3.3, then you correct your hypokalemia first. You give 40 milliequivalents of potassium in one hand, and in the other IV line you can give your insulin. So you correct your hypoglycemia, please cut the last line. You correct your hypokalemia first and then you go with your insulin correction. So initial serum potassium, if it is less than 3.3, do not administer insulin until the potassium is corrected. Okay, because it can worsen the hypokalemia. So that is about your hypokalemia. Okay, after this you see whether what is the cause that precipitated your DKA. You assess the patient and assess what is the cause that precipitated the DKA. Was it non-compliance, infection, trauma, infarction? And you will have to do or run a set of investigations. Get an ECG, get a CBC, get a chest X-ray, get cultures, see what you are looking at and take a good history whether they missed a dose of insulin. Okay, fine. So this is about your monitoring. Measure the blood glucose every 1 to 2 hours. Measure your electrolytes, especially your bicarb in the ABG, potassium phosphate, anion gap in your first 24 hours. Apart from this, you will have to monitor the vitals as well. Monitor the blood pressure, pulse, respiratory rate, mental status. Monitor your hydration status, urine. So till here we are clear, right? So after this, what do you do? Very importantly, what is the indication for bicarbonate? What is the indication for bicarbonate? We do not give bicarbonate in the management of DKA unless the pH is less than 6.9. Unless the pH is less than 6.9, there is no role of bicarbonate replacement. You only give it when the pH is less than 6.9. Okay, fine. And when you are giving IV insulin as a continuous infusion, there is a risk of potassium depletion. So you may have to replace potassium at 10 milliequivalents per hour if there is hypokalemia. Okay, if there is hypokalemia. You continue this process of IV fluids with IV insulin and you change the IV fluid to your maintenance of 0.45 NaCl with 5D when the blood glucose drops to less than 250. What are your endpoints? What are your endpoints in the management of DKA? So the endpoints in the management of DKA is not only normalization of sugars, it is resolution of acidosis. It is resolution of acidosis. The patient's mental status is normal and the patient is able to take food. Patient is able to take food. Then that is when you convert your IV insulin into your subcutaneous insulin. So that will be the end point in the management of DKA. So you convert your IV insulin into your subcutaneous insulin. So how do you calculate this? You take the total dose of insulin which has been going on as an IV infusion over the past 24 hours, and that will give you the total estimated dose of insulin requirement. And then what you do is about 50% of the dose. About 50% of the dose you have to convert it into basal, 50% of the dose you have to convert it into bolus. So what dose you get for your bolus, you administer it as a bolus regimen. So that means that your basal regimen is usually a long-acting insulin. Your bolus regimen is usually your short-acting insulin like regular insulin. So your total dose what you calculated, you split it as 50-50 basal and bolus. What dose you get for your bolus, you administer it. So for your normal insulin, you may have to administer it 30 minutes before you taper and stop off your IV insulin. So suppose the dose is around 10 units, you give 10 units of normal insulin subcutaneously and then you taper and stop off your IV insulin once the end point is reached. Okay, so this is about your management for diabetic ketoacidosis. So this may sound complicated initially, but it is not so complicated. Just remember the hallmark features, just remember the high important points that have to be highlighted. That is, assess the patient, confirm the diagnosis of DKA. The two most important things you have to consider is IV insulin and IV fluids. Okay, monitor the blood glucose well, and once the blood glucose reduces to less than 250, change your IV fluids to maintenance of 0.45% NS along with 5D. Also monitor for hypokalemia, ABG status. Once the acidosis has resolved, the patient's mental status is normal, patient is taking food well, then you can change to your subcutaneous insulin. Never forget to find out what is the underlying cause for precipitation of your DKA. Okay, so this is about the management of DKA. The management of HHS is also very similar. You do this similar fashion for the management of HHS as well. Fine. Okay. So with this we have understood what are your acute complications of hyperglycemia or your DKA, HHS and your euglycemic diabetic ketoacidosis. Now we'll move on to the other complications. The other complications, this list we have seen before as well. So this is your microvascular and macrovascular complications. Your microvascular complications include your retinopathy, neuropathy, nephropathy. So your microvascular complications include your retinopathy, neuropathy, nephropathy. The macrovascular complications are coronary arterial disease, peripheral arterial disease and your cerebrovascular disease or stroke. Other complications include GI, GU, where you can have gastroparesis, you can have neuropathy, dermatologic, infections, cataracts and glaucoma, periodontal disease, cheroarthropathy. So these are the various diabetes related complications and we'll be looking at the main complications one by one. So what are the mechanisms of these complications? Why do you get these complications in diabetes? So most importantly, chronic hyperglycemia results in the formation of what we call as your advanced glycosylation end products or your AGE. Okay, so chronic hyperglycemia results in the formation of AGE. So this AGE is responsible for cross-linking of proteins, it is responsible for endothelial dysfunction, alteration in your extracellular matrix. This is your extracellular matrix. And then it causes increase in the amount of reactive oxygen species. It promotes atherosclerosis. Okay, so these are the ways in which advanced glycosylation end products can result in your varied complications. So first we took at your microvascular complications, which is retinopathy. So what is the basic pathophysiology of diabetic retinopathy. So diabetic retinopathy, it basically occurs because this AGE or the advanced glycosylated end products cause loss of your retinal pericytes. There is loss of your retinal pericytes and damage to your blood retinal barrier. There is loss of your retinal pericytes and damage to your blood retinal barrier. There is alterations in the flow within the retina, and finally it results in retinal ischemia. Okay. So what are the types of retinopathy? It can be classified as your non-proliferative diabetic retinopathy, non-proliferative and proliferative diabetic retinopathy. So the clinical classification of diabetic retinopathy is NPDR and PDR. So NPDR mainly comprises of microaneurysms and hemorrhage. As the disease advances, you can have the formation of neovascularization. You can have neovascularization because of damage to the vessels, and when there is damage to the vessels, there is new artery formation as a compensation, and the moment neovascularization develops, it is a proliferative diabetic retinopathy. So in your NPDR, you can have microaneurysm formation, you can have hemorrhages within the retina, and you can have protein exudates. You can have protein exudates, which we call as your hard exudates. But as the disease progresses, your NPDR becomes your PDR and you can have neovascularization. So can you see here? You can see that there is damage to the vessels and these are your hard exudates. Okay. And can you see some, as the disease progresses, you can have connections between the vessels which is your PDR or your neovascularization. Here you can see some amount of hemorrhages as well. So there will be protein leak, there will be microaneurysms, hemorrhage, and finally PDR. Okay. In later stages, you can have macular edema also. So why is it that you should be aware of this diabetic retinopathy? Because one thing is, diabetic retinopathy is one of the very, very important causes for reversible blindness. So diabetic retinopathy is one of the very, very important causes for reversible blindness. But apart from reversible blindness, if a patient has diabetic retinopathy, on your screening, when you do a dilated fundus examination, there is a 60% chance that he has nephropathy as well. Okay, there is a 60% chance that he has a nephropathy as well. That is the reason why screening for diabetic retinopathy is very, very important. Okay, fine. Okay. Now let us understand the monitoring and treatment of diabetic retinopathy. So in type 1 diabetes, you have to monitor using a dilated fundus examination every 5 years. You do in your dilated fundus examination every 5 years. But in your type 2 DM, at diagnosis itself, you have to do a fundus examination and do a fundus examination yearly to look for diabetic retinopathy evidence or look for the progression as well. So, treatment of diabetic retinopathy. The drug of choice is your intravitreal anti-vascular endothelial growth factor agents. Why do we use these VEGF agents? Because VEGF plays a very important role in your microaneurysm formation, in your neovascularization. So, anti-VEGF agents like your bevacizumab, intravitreal bevacizumab is used in the treatment of diabetic retinopathy. In the later stages, you can also use pan-retinal photocoagulation. So, intravitreal VEGF and pan-retinal photocoagulation or PRP is the treatment for your diabetic retinopathy. Apart from this, you have to manage your sugar as well. Okay. So, this is about DR. The next complication is your diabetic nephropathy. So, what is the pathophysiology of diabetic nephropathy? So, the basic pathophysiology of diabetic nephropathy, to understand that, we have to understand the natural history of diabetic nephropathy. Okay. So, the initial stage in the first 5 years of your diabetes, what happens is that there is glomerular hyperfiltration. So what happens is that this uncontrolled sugars, result in the formation of advanced glycosylated end products which can cause podocyte damage. They can cause podocyte damage and protein leak. Okay, there can be podocyte damage and protein leak. In the first 5 years of your diabetes, you have glomerular hyperfiltration. There will be mesangial expansion and the glomerulus is actually hyperfiltering. There is hyperfiltration. Then there can be thickening of the glomerular basement membrane. So in the initial stage, if you pick up diabetes, you can pick up diabetes nephropathy, you can prevent CKD. Okay, you can prevent CKD. So after that, in the next 10 years, there is albuminuria. So there will be damage to the podocytes and there is albuminuria of more than 30 mg per gram. So once the albuminuria sets in and the GFR begins to decline, then the rate of GFR decline is about 8 to 10 ml per year. It is about 8 to 10 ml per year. So this means that they can go into CKD within 2 to 3 years. They can go to CKD within 2 to 3 years. Okay. So finally, it results in your end-stage kidney disease. So it's very, very important that you pick up your nephropathy in the first 5 years because in this stage, you can reduce the proteinuria. If you reduce the proteinuria, then the progression into CKD is slower. And the drugs which are used here is your SGLT2 inhibitors and your ACE-ARBs. So this ACE-ARBs and your SGLT2 inhibitors can retard the progression of diabetic nephropathy. Okay, fine. So this is about your natural history of diabetic nephropathy. So screening. So how do you do your screening? So in your type 1 diabetes, again, you will have to do screening for diabetic nephropathy every 5 years. In your type 2 DM, you will have to do it at the diagnosis itself and do it every 1 year. And how do you screen it? You look for urine albumin creatinine ratio, or now the newer test is your urine microalbumin. Okay. So who are at a risk of diabetic kidney disease? A strong family history of diabetic kidney disease is a risk factor. And those patients with diabetic retinopathy have an increased risk of diabetic nephropathy as well. Okay, this is about the screening for diabetic nephropathy. What is the hallmark pathological feature? You can find that you have some nodular changes and this is called as nodular glomerulosclerosis. So you have nodular glomerulosclerosis where you have nodule formation within the glomerulus and the glomerulus becomes sclerosed. Glomerulus undergoes damage and becomes sclerosed. So this is what we call as your Kemmelstein-Wilson's nodules or nodular glomerulosclerosis, which is the hallmark pathological feature of diabetic nephropathy. Clear? Now let us look at the management. Again, this is from your ADA 2025 update of management of diabetic nephropathy. So this is very, very important because it is one of the most common causes of CKD in India. So promote lifestyle measures, right? Promote healthy eating, physical activity, smoking cessation and weight management. And you do a regular risk factor assessment every 3 to 6 months. The first line therapy in the management of diabetic nephropathy before it goes and progresses towards end-stage renal disease is your SGLT2 inhibitors, which is your wonder drug which we had discussed. So SGLT2 inhibitors, dapagliflozin, empagliflozin, retard your progression of diabetic nephropathy. So if the eGFR is more than 20, you continue SGLT2 inhibitors until dialysis is initiated. Okay. Apart from that, metformin can also be used. The second group of drugs is your RAS inhibitors, which is your ACE inhibitors and ARBs. Because they also help in decreasing the proteinuria of diabetic nephropathy. And always monitor for your dyslipidemia and give a moderate to high intensity statin. Because atherosclerosis can affect the renal arteries as well. So look at your dyslipidemia. Then regular assessment of glycemia, cardiovascular risk disease, albuminuria, lipids. Okay. Then based on your additional risk factors, based on your additional risk factors. Based on your additional risk factors, you have to think of additional treatment as well. So if your glycemic improvement is not there, you can consider adding GLP-1 receptor agonist. So you can consider adding GLP-1 receptor agonist. Okay. The other pillar in the management of diabetic nephropathy is your non-steroidal MRA. The non-steroidal MRA, which is finerenone. Okay. So the newest drug which is used in the management of diabetic nephropathy is your non-steroidal MRA or your finerenone. Okay. So you do a good control of your blood pressure, good control of your other associated cardiovascular risk factors like dyslipidemia. Initiate them on SGLT2 inhibitors, ACE/ARBs and your non-steroidal MRAs like finerenone. Then if the hypertension is not controlled even on that, then you can use calcium channel blockers. You can use calcium channel blockers. Okay. And you can start them on antiplatelets like low dose aspirin as well. So the most important drugs or the pillars in the management of diabetic nephropathy is your SGLT2 inhibitors, your RAS inhibitors like your ACE/ARBs and your non-steroidal MRA like finerenone. And you look at the other cardiovascular risk factors like dyslipidemia and start them on low dose antiplatelet. Okay, fine. So that is about your diabetic nephropathy. The next group of disorders or the next complication that we should be aware of is your neuropathy. Okay, is your neuropathy. So how does diabetes affect the nerves? There are various ways in which diabetes can affect the nerves. So first is your polyneuropathy. So what do you mean by polyneuropathy? So polyneuropathy is characterized by distal symmetric length dependent. So this is characterized by distal symmetric length dependent neuropathy. Distal symmetric length dependent neuropathy. So what is the meaning of that? So the basic symptoms with which they present is paresthesia or burning sensation in the feet, and if it becomes severe and progressive, then there can be loss of sensations as well. Okay, so what is the meaning of this distal symmetric? So distal symmetric means it predominantly involves the distal portions, especially your feet and hands, and it is symmetric in nature. Both the feet, both the hands will be involved. And what is the meaning of length dependent neuropathy? Length dependent neuropathy means that there is involvement of the lower limbs first. Okay, there is involvement of the lower limbs first and until it progresses beyond the knee. So once your neuropathy progresses beyond the knee, that is when you can have involvement of your hands. Okay, so this is what you mean by a length dependent pattern, and this pattern is what we call as your glove and stocking pattern. This is what we call as your glove and stocking pattern, right? So if you see an individual with diabetic neuropathy, it is usually having a glove and stocking pattern of neuropathy. So your distal symmetric polyneuropathy is the most common form of nerve damage in neuropathy in diabetes mellitus. Then the next type is diabetes patients can have autonomic neuropathy. Diabetes patients can have autonomic neuropathy. So this autonomic neuropathy, how do you identify? It is characterized by resting tachycardia. It is characterized by resting tachycardia. It is characterized by orthostatic hypotension. It is characterized by resting tachycardia, orthostatic hypotension. Apart from that, involvement of your autonomic nerves, whenever there can be damage to the autonomic nerves, for example, in your GI system, it can result in gastroparesis. So they will have a delayed emptying of the food. So they can have bloating, they can have stomach fullness, and involvement of the autonomic nervous system can also cause diarrhea. So they can have diabetic diarrhea. And involvement of the nerves of the genitourinary system can result in something called as diabetic cystopathy. where they have a voiding problem. They have a voiding problem. You can have urinary retention and frequent UTIs because they have a difficulty in voiding. So treatment of diabetic cystopathy involves maybe your self-catheterization, removal of urine. Okay, fine. Another very important component of autonomic neuropathy is what we call as hypoglycemic unawareness. So whenever you have autonomic neuropathy, your sympathetic reflexes are blunted. So your sympathetic reflexes are blunted. So whenever you have hypoglycemia, what are you expecting? Whenever you have or whenever a patient has hypoglycemia, what will happen? There will be an increase in the counter-regulatory hormones. There will be an increase in the counter-regulatory hormones. So what are your counter-regulatory hormones? The catecholamines, the glucagon, so that they try to increase the blood glucose. So when these counter-regulatory hormones are released, you will have tachycardia, you will have sweating, you will have dizziness, tachycardia, sweating. But this does not happen in a patient with chronic long-standing autonomic neuropathy because your sympathetic reflexes are blunted, and this results in what we call as hypoglycemic unawareness, which is a very dangerous situation. They have hypoglycemia, they are unaware of that. They do not have sweating, they do not have dizziness, they do not have tachycardia. Okay, so this is about the various ways in which autonomic neuropathy can present. Okay, this hypoglycemic unawareness is more so common in the night because your sympathetic reflexes are more diminished. So they can have hypoglycemia in the night, which is very, very dangerous because it cannot be identified by the family members as well. Alright, so this is about your autonomic neuropathy. The other ways in which diabetes can affect the nerves is that you can have mononeuropathy and especially cranial nerve neuropathies. So mononeuropathy means involvement of one particular nerve, one particular peripheral nerve, most commonly median nerve, which can be compressed in your carpal tunnel syndrome. And they can have isolated cranial neuropathies. So cranial neuropathies, most common nerve that is involved is your cranial nerve 3. So you can have cranial nerve 3 damage resulting in ophthalmoplegia or a down and out eye. Down and out eye. In a third cranial nerve paralysis, you can have a down and out eye, and this is usually a pupil sparing defect. The pupils are not affected. Other cranial nerves which can be involved is your 4th cranial nerve, 6th cranial nerve, 7th cranial nerve. So you can have ophthalmoplegia, you can have facial palsy as well. Then you can have something called as radiculopathy. You can have radiculopathy where 1 or 2 radicals are involved and can have proximal weakness. Then plexus involvement. Plexus involvement can result in a condition where you have asymmetric weakness, which is predominantly proximal weakness. Asymmetric proximal weakness with a lot of pain and wasting. And this is what we call as diabetic amyotrophy. This is what we call as diabetic amyotrophy. Okay. So these are the various ways in which you can have diabetic neuropathy, and the most common symptom is your diabetic distal symmetric polyneuropathy. Okay, fine. So how do you manage? Most of the time when diabetic patients are on chronic metformin use, they can have an associated B12 deficiency, so you correct the B12. The 2 FDA approved drugs for your painful diabetic neuropathies are your duloxetine and pregabalin. Fine. Tapentadol is also basically another sympathetic opioid with analgesic properties, and this is also been FDA approved for diabetic neuropathy. If there is orthostatic hypotension because of autonomic neuropathy, then the drug of choice will be midodrine. So how do you identify this? You identify this using your orthostatic hypotension. When you check the blood pressure when the patient is standing, systolic blood pressure falls by more than 20, diastolic blood pressure falls by more than 10. If that also is not seen, then you can do your autonomic function testing to identify this. Okay. So in orthostatic hypotension, the first line treatment will be to increase your fluid intake, increase your salt intake, and you counsel the patient to get up slowly and be aware of recurrent falls. The drug of choice for the management of orthostatic hypotension is your midodrine. Okay. Sometimes fludrocortisone can also be given, which is your mineralocorticoid, synthetic mineralocorticoid fludrocortisone. So this is about your diabetic neuropathy and management of diabetic neuropathy. Now let us move on to your cardiovascular complications. Cardiovascular complications predominantly have your coronary artery disease. The drugs which have a cardiovascular benefit is your SGLT2 inhibitors. Apart from that, every diabetic patient has a high risk of atherosclerotic disease, and hence you have to do a screening for lipids, screening for your CAD using a regular checkup like a treadmill test, regular ECG, echo treadmill test, or even your cardiac CT, right? So in those patients with an increased atherosclerotic cardiovascular risk factor, you start them on ecosprin. Low dose antiplatelet ecosprin at 75 mg per day. When it comes to the lipids, you target an LDL of less than 70 milligrams per deciliter. So your target LDL will be less than 70. So what do you use? The drugs are statins. If the target is not reached with the statins, then you can give them ezetimibe. You can give them ezetimibe, or you can give them PCSK9 inhibitors. You can give them ezetimibe or PCSK9 inhibitors. Okay. Another very important part of your cardiovascular risk factor management is the management of blood pressure. The first line drugs is your ACE inhibitors or ARBs, which is your losartan, telmisartan, and your ACE inhibitors is your ramipril. Okay. So these are the drugs used in the cardiovascular manifest. Please cut the last line. So these are the drugs used in the cardiovascular risk factors or cardiovascular disease management with diabetes. So the next important complication is your diabetic foot. Okay. So diabetic foot is an important complication of long-term diabetes. So what are the causes? What are the causes for your diabetic foot? We know that patients with diabetes long-standing can have neuropathy. So when they have neuropathy, ultimately there will be loss of sensations. So when there is loss of sensations, they are more prone to trauma, they are more prone to falls, and they can be, this can result in your diabetic foot and diabetic foot related complications, including your neuropathic ulcer. Apart from this, there can be abnormal mechanics. Over time, this chronic neuropathy can result in joint damage to your tarsal bones. Can you see here that the tarsal bones are completely destroyed, and this is what we call as the Charcot's joint. Okay, fine. So abnormal mechanics, and there will be abnormalities in your weight bearing because of damage to the joints. Then peripheral arterial disease. Diabetes causes atherosclerosis not only in the heart, it can affect the peripheral arteries also. So overall there is damage to the peripheral arteries, then you can have arterial ulcers. Apart from that, the nutrition to the foot is lost, as a result of which these arterial ulcers and gangrene formation can happen. Can finally result in gangrene as well. Okay. And most importantly, the problem with all of these ulcers, and because of there can be repeated trauma, and this predisposes to repeated foot infections as well. These infections can be because of staphylococci. These infections in worst cases can be because of Clostridium as well. So there can be repeated foot infections. Initially, it may be limited to the ulcer. Later on, it can progress to osteomyelitis as well. So the other factor which is responsible for your problem with your diabetic foot is your poor wound healing. Okay. So these are the various risk factors which are responsible for your problems with diabetic foot. The most common site of your diabetic ulcer is over your first metatarsal or near your first toe. So how do you prevent? The most important step in the prevention is educating the patient about your proper foot care. Tell them to clean their feet thoroughly every day. Then the second step would be that they should be aware of the neuropathy and neuropathy related complications. And be careful and avoid trauma. Okay. Third is that you have to control your sugars well, so good glycemic control. Okay, good glycemic control. Fourth, apart from all of this, you will have to do a regular screening. You will have to do a regular screening of the foot as a healthcare provider whenever the patient comes to you. Do a regular assessment. And what do you do in your regular screening? You can use an esthesiometer. You can use an esthesiometer, and this is used to find out where all there are sensory deficits for early identification of neuropathy. Okay. Apart from that, you will frequently look for calluses, frequently look for damage and provide adequate treatment. Then fifth, you provide them with offloading therapy and physiotherapy. Refer them to a podiatrist early so that they can take care a comprehensive management of foot care can be provided. Offloading therapy means it's a type of physiotherapy where they teach the patient to offload from your damaged foot and how do you do your weight management, how do you walk, and so on and so forth. Very importantly also, the next step is prescription of footwear. Prescription of appropriate footwear which are designed for your diabetic foot to ensure that their mobility is maintained. Okay, and prompt treatment of infections is also very important in preventing the complications of your diabetic foot. Okay, so this is about your diabetic foot. The next complication and amongst the last complications that we should be aware of is your dermatologic complications. So the most common complication is your xerosis. There can be a lot of dryness of the skin and itching. Then the other common skin manifestation is your diabetic dermopathy, which is called as pigmented pretibial papules. For these, you can give some local emollients and that's about it, and good glycemic control. Diabetes can be associated with some form of bullous skin disorders, which we call as bullous diabeticorum. Okay, bullous diabeticorum. The other skin manifestation is your lichen planus, which is a purple pruritic polygonal papules. Okay, this is most often due to unknown autoimmune process where you have purple pruritic polygonal papules, but most commonly it is associated with diabetes as well. The most severe form of a dermatologic manifestation is your necrobiosis lipodica dermaticorum. Sorry, please cut the last line. So the most severe manifestation of your dermatologic manifestation of diabetes is necrobiosis lipodica diabeticorum, where you have a deep ulcer. There can be deep ulcer formation. Treatment of this would involve debridement and adequate antibiotic therapy. Okay, fine. So this is about the various complications of diabetes. Fine. So we have understood what are the microvascular, what are the macrovascular. Under the microvascular, we have learnt management of neuropathy, nephropathy and retinopathy. Then we have looked at the other complications including your diabetic foot and dermatologic complications. Okay. So with this we have come to a huge, so with this, please cut the last line. With this we have come to the end of this huge chapter on diabetes mellitus and its complications. Thank you.